now come to the reproductive endocrinology. This is the picture showing to you just to refresh the physiology and anatomy. You see that LH, FSH, gonadotropin coming down, exerting the effect on the testes and the ovary here. Ovary, maybe it is, we are dealing a patient, male patient, for that it is written as testosterone. And you see that there is an fascination of activities. LSH acting over the Leydig cell, FSH acting over the spermatogenetic activities. Okay, you see the interstitial cells of Leydig. Okay, interstitial cells of Leydig. And you see it is influence of the spermatogenesis, FSH. From this cell, there is inhibin giving the negative feedback, and the testosterone giving the negative feedback in the pituitary gland. Inhibin and testosterone. So the interstitial cells of the Leydig, remember it. Okay, and the Sertoli cell, you see the FSH working on the Sertoli cell. The Leydig, LH, L for L. LH exert on Leydig, L for L. Dr. Hadil, I think you understand what I mean. Just to remember, L for L. And these are the effects of testosterone. Okay. There's very interesting information, but I will not tell. Just remember this physiology. And one question is common, the libido. Libido, remember here. The libido is mediated by the testosterone, even in the female. Remember it. The female libido depends upon the level of androgen in the body, not the estrogen and other. Especially the libido. Remember it. These are the ovulation physiology, you see. The follicular phase, luteal phase. And the luteal phase, the progesterone is secreted. There is a question I can remember. Maybe you can remember in our previous, the recall session. In which day the progesterone secretion become more. That means if you want to do the investigation to check the level of progesterone in the cycle, which day is better? Can you give the answer now by looking at the picture? To check the highest level of progesterone, which day is better?
First.
What, doctor?
21st.
21st, better. If you send this one, you see, progesterone is the green color, the maximum level around the 21. That means in the 3rd week, usual cycle, 3rd week. So we need to know it. Otherwise, it will be falsely low. Falsely low. And there is a positive feedback issue for the ovulation. Estrogen level is high, gonadotropin level also.
Cycle 35.
Sorry, doctor.
If cycle duration 35 days.
Actually, 7 days after the ovulation. The luteal phase is fixed. The last 14 days is fixed. So 35 means, suppose 21st day at the time of ovulation. Right, doctor? And 21st day is the day of ovulation expected. So the level will be the 28th day. The progesterone level will be checked on the 28th day if the cycle is 35. I think it is clear. Dr. Hind, clear to you?
Yes.
Okay. Dr. Rashid, please read the question now.
A 25-year-old woman attends clinic troubled by long-standing facial hirsutism. She has been amenorrheic for 6 months. On examination, she is overweight with a BMI of 31 kg per meter square and has a blood pressure of 140/85. She denies the possibility of pregnancy. Which of the following is likely diagnosis?
So again, there's a summary, the features of the hyperandrogen, but not too much severe. Features of hyperandrogen, state of hyperandrogen, 25-year-old woman. BMI is high. She is not pregnant. What is the underlying disease? Huh?
PCOS.
PCOS. So these are the picture of the ovary by the ultrasound. The polycystic ovary, the sister like that in the peripherally, this is arranged. This is the description of the polycystic ovary. But interesting is that for diagnosis of the PCOS, the presence of cyst is not mandatory. For the diagnosis, the main issue is state of hyperandrogenism. That is the level of the androgen is high in this patient, PCOS. Again, this is a very important topic in the exam and again common in the OSCE station. So we need to know the details of the PCOS, including its treatment. Okay. So now the differential diagnosis of the hirsutism. These are the three, including the PCOS. It is called hyperandrogen state. Try to remember, doctor, the differential of the hyperandrogen state. This is the tumor in the ovary or adrenal gland. That is the tumor in ovary, adrenal gland secreting the androgen. This is the most severe clinical presentation, very gross features. Another one may be Cushing, another one congenital adrenal hyperplasia, and PCOS. So try to remember this, the state of hyperandrogen. Now come to the features of the weight loss and weight gain issues. So Dr. Hadil, are you there? I am requesting doctor, please keep your hand raising if you are free so
Yes.
that I can understand to call you one by one. Please go through.
Okay. 60-year-old lady with lipidemia, hypertension, and angina has recently been diagnosed with impaired glucose tolerance. Clinically, she is obese with body mass index 32. Her blood pressure is 140/80. Which of the following has been showing best to reduce the incidence of type 2 diabetes, individuals with IGT?
So type 2 incidence, what medicine you will give? Patient has the dyslipidemia, BMI is high, sugar level in the impaired level. That means the pre-diabetic state.
Pre-diabetic and
So,
BMI.
so reduce the incidence of type 2 diabetes individual with IGT. If it reduce the chance, it will not prevent. Totally, total prevention is not there, but which drug?
metformin.
Instead lifestyle.
Okay.
So all of us become foolish now. If I ask you the drug, then drug. But other than drug, body mass index and others, dyslipidemia, everything will be the corrected by the lifestyle. As STEM is separated, doctor, remember. If it is said that intensive lifestyle with the metformin, you can choose, but till now in the IGT, metformin is not recommended by any author. In our practice, we are giving sometime metformin, but the lifestyle. And this is the pyramid, doctor. BMI is more than 27. If patient have the diabetes or heart disease and other, we can consider the drug or listed. But only obesity without any comorbidities, the drug consideration maybe after 30 BMI. And after 40 is the surgery, operation. And in the comorbidity state, after 35, surgery will be the decision. As a GP, we need to convey the message to the patient. So first of all, the intensive lifestyle is the first thing. Second thing, if patient is impaired glucose tolerance, you may consider to give orlistat as well, but not metformin. For the body weight reduction, orlistat will be the treatment in addition to the lifestyle. Okay. Now, something about the diabetes insipidus. That according to the importance, I make the sequence, doctor. Suppose weight and other issues, then coming to the pituitary with the diabetes insipidus. Now, doctor, who will read? Dr. Hadil, please.
Okay. A 60-year-old girl is noticed to have persistent polyuria in excess of 4 liters per day while recovering from a head injury. She sustained it in a road traffic accident. Investigation
So
revealed.
doctor, now try to understand the background in the other than investigation. Always think symptom and sign first before going to the investigation. This is very, very typical thing. So what we get the message from there? Patient have a road traffic accident. Okay. Now patient drinking 4 liters per day after the road traffic accident. Is there any clue that patient might have problem of the water intake? What do you think? Any injury to the pituitary gland can cause the pituitary problem? Yes, road traffic accident. So now come to the investigation. Actually, what problem happening in the pituitary gland? Look at the investigation now.
Potassium 4.1 normal, calcium 2.4 normal, glucose 5.6 within normal range.
So all are normal. All are normal, but patient is drinking more. So is it diabetes mellitus?
No, glucose normal range.
So it could be what else? As injury is there, patient drinking more.
Diabetes insipidus.
Yes, diabetes insipidus could be there. Patient is drinking more due to the road traffic accident. It will be called as the cranial diabetes insipidus. Cranial. Another is renal diabetes insipidus. So the cranial means within the cranial cavity, pituitary gland is problem. Now, what will be the diagnostic test to confirm underlying diabetes insipidus? Answer, please. Water deprivation test. Water deprivation test. Up to this enough, doctor, for diabetes insipidus. No need to discuss more. In the GP level, AKT exam will not give complicated, and deprivation test, how it is done, not needed. You just remember the confirmation of the diagnosis of diabetes insipidus is by water deprivation test. So diabetes insipidus is not uncommon after head injury. So remember it. So are the common pituitary condition? Just to discuss something, the details data is here. All the pituitary problems are listed here, doctor, and the hypopituitarism situation and the hormone access situation. I hope that you will read it by yourself. In the terminology of the macroadenoma and the microadenoma, it is a 10 millimeter size. Is less than 10 millimeter, it is called microadenoma. If more than 10 millimeter, it is said as macroadenoma of the pituitary gland. And this is that impact hypothalamus, especially showing the activities of the prolactin. You see the LSH, LH, gonadotrophin axis is here, prolactin. Just to inform you that prolactin is a hormone which inhibits in all the stage of the reproductive hormone, means estrogen, progesterone. So prolactinemia can cause hypogonadism. Though it secretes the more the milk from the breast in the female, but it causes suppression of other the sex hormones. How it decreases the secretion from the above down, and it inhibits the action of the reproductive hormone. You see the red, negative. So it's giving the feedback, negative feedback in the up, and giving the negative impact in the down also, the prolactin. But only the lactation prolactin. So in the hypogonadal state or some maybe sex drive related issue, we are checking the prolactin level sometime.